Hi everyone, I'm Ed Highland and this is ASA TV. I'm joined now by ASA's Chief Quality Officer, Alex Hannenberg. Dr. Hannenberg, thanks for joining us. Let's jump right into it if we could. And if you could give us an update on quality and regulatory affairs and how they are working very closely with ASA members to ensure that they have satisfactory access to federal quality control programs.
Right, that's a really important question. We have such a diversity of anesthesia practices. Think about the different practice settings, office, ambulatory surgery, hospitals. Think about the variety of subspecialty practices. Think about the size and resources available in different practices. So mostly what we're trying to create, working in advocating with federal payment programs, is that those programs are adaptable and are made feasible for that broad range of anesthesia practices. Part of that is having an adequate range of quality measures to report for those payment programs. And we are at a little bit of a loggerhead with the Centers for Medicare and Medicaid Services, who, in a well-intentioned desire to simplify and reduce reporting burden, are on a bit of a campaign to reduce the number of available measures. Our view is that as long as the number of measures an individual practice or clinician needs to report is reasonable, a broad range of choices is most desirable. So we have been, for example, partnering with the American Society of Regional Anesthesia and Pain Medicine and the Society for Ambulatory Anesthesia to develop measures that are important measures for people practicing in their areas, and we intend to continue to do so because this is one area where one size cannot possibly fit all. We view the MIPS reporting requirements in quality improvement activities, EHR use, and cost as a transitional platform. And all of the incentives are aligned to drive clinicians to participate in alternative payment models, which de-emphasizes the place of fee-for-service payment. That is the future. And so we are keeping an eye on building opportunities for anesthesiologists to benefit from those practice models, at the same time understanding that some number will remain in the MIPS program for a period of time. Now, the happy story really is that Medicare's interest in accommodating the needs of clinicians in different settings has provided lots of options. A lot of anesthesiologists will be able to exempt themselves from reporting for MIPS, and it comes with a price. It comes with the price of essentially frozen fee-for-service payments for a really extended period of time. So it's not really that attractive, but it's an option, and it does obviate the need to invest in data capturing and transmission capabilities. One interesting thing that is coming online in the coming year is the opportunity for the quality and cost components of MIPS to be reported through a proxy using the hospital's value-based purchasing reporting metrics. In that model, anesthesiologists can either not report on those areas and have Medicare give them the benefit of whichever is more favorable, their hospital score or their own MIPS score. So that's an interesting option. I regard it as a positive first step, perhaps an awkward step, in the direction of what I think is really suited for our specialty, that is shared accountability. There are very few patients that anesthesiologists interact without other clinicians and without a significant influence on outcomes by the structure, by the hospital. And so those measures that I refer to as shared accountability, I think most closely match how we practice and opens the door to reporting on outcomes that are important to us and our patients, as opposed to the process measures, which tend to be more of the check-the-box type.
So Dr. Hannenberg, if you're not required to report for MIPS, why is there a need, or should you do so?
Yeah, I think that if you are exempt from MIPS reporting, you should definitely be thinking about reporting for a whole different range of purposes. The Anesthesia Quality Institute's registry contains measures designed for MIPS reporting endorsed by CMS, a range of measures that the registry itself sponsors, and a whole bunch of what we call internal improvement measures that are measures that have come from practices as representing what they think is important for quality monitoring. Now, if you're not reporting to the federal government for payment programs, think about how important being able to demonstrate the quality of your practice will be in your contract with your hospital. Those are just a couple of examples of the benefit to the practice locally, benefit to the practice in negotiating contracts with third-party payers. We're all about paying for quality care. You have a real need to be able to demonstrate the quality of care and see that translate into the terms of your contracts for payment for the services you deliver. We think that ultimately where you want to be in the future is in an alternative payment model. And in that respect, the kind of work that's being done in our perioperative surgical home learning collaboratives is incredibly well suited to making those alternative payment models more successful. So to the extent that anesthesiologists can coordinate and lead efforts working alongside surgeons and institutions to effectively manage surgical and procedural care, tremendous opportunity to improve the performance of alternative payment models, and for anesthesiologists then to be able to share in the benefits of shared savings and other incentives that go along with it. So my advice to anesthesiologists is to literally knock on the door of the C-suite in their faculty practice plan hospital health system, find out what's going on with respect to alternative payment models, and present the very rapidly growing body of evidence about care coordination for the surgical patient, improving outcomes, reducing cost. And this is an important point, doing so in a relatively rapid cycle fashion. So if you think about the benefits of managing chronic diseases like diabetes or heart failure, the benefits to the bottom line are delayed, years, maybe decades. If you improve the outcomes and the cost of delivering care in a spine operation or a colon operation, the return on investment is realized in a period of months. And that ought to be a very persuasive argument to the leaders of alternative payment models in hospital systems to be able to welcome that kind of contribution to the exercise from anesthesiologists, surgeons, nurses, and the other people who deliver perioperative care.
A wealth of information. Thank you so much, Dr. Alex Hannenberg. And this is ASA TV.